Good morning. Today we are going to present an interesting case that we managed in our OPD, and we learned a lot out of that case. It's a case of 26 years old Hindu female who is a homemaker by profession, by occupation, and she is educated up to 10th of standard. She is a resident of Bijnor, Uttar Pradesh. She came to us in our OPD in AIIMS Rishikesh in August 2022 with chief complaints of mass at her left lateral border of foot for 4 months, right supraclavicular lymph node enlargement for 2 months, low back pain for 1 month, and a generalized weakness for 1 month. She did not give any history of pain, abdomen, abdominal distension, urinary complaints, or altered bowel or bladder habits. There was no cough, breathlessness, hemoptysis, jaundice, headache, or vomiting, and there was no history of any trauma. Her history of present illness are as followed. About 4 to 5 months back, she noticed a lump on her left foot near the left little toe. It was size of a pea when she noticed it first. It was painless and rubbery in consistency. Gradually, the size increased over another 3 to 4 months, and it was not associated with any aggravating or relieving factors. Subsequently, she noticed a swelling at her left supraclavicular region with a similar feature. It was rubbery. It was again size of a pea when she initially noticed. She started having low back pain with weight loss and a generalized weakness and on and off low grade fever, which she don't have any documentation, but she told about, for which she took some symptomatic treatment local. She lost about 5 kgs of weight over last 4 months, what she told to us. She consulted a local surgeon and got an FNAC done from her left foot lump, which was suggestive of a malignant small round cell tumor, for which she was referred to AIIMS Rishikesh for further management. Her past and personal histories are as followed. As such, her personal history: she is a housewife, educated of 10th of standard, on a mixed diet, without any addiction or a history of any passive smoking. And she has got a normal bladder and bowel habit. Past medical and surgical histories were as such non-significant. Her family history was not significant for any chronic illness, malignancy, or similar complaints what she presented with in her family. Her menstrual obstetrical histories are as followed. She is para-1 live 1 with a 3-year-old son from an uneventful normal vaginal delivery. She is having a regular menstrual cycles with average flow. She is not currently breastfeeding, and there is no exposure to any types of OCPs. On presentation, we examined her. She is ECOG PS2, which means she is awake, alert, and is active, and can carry out her day-to-day carry out her self-care, but she cannot do any activity or any work because of her disease symptoms. Mostly here she had back pain and generalized weakness, for which she is labeled as ECOG PS2. On general examination, she had pallor, but as such no cyanosis, clubbing, or edema. Right supraclavicular lymphadenopathy was present. Thyroid and breast examinations were within normal limit. Her vitals were normal with a pulse of 82 per minute with normal sinus rhythm, and blood pressure was 122 by 76 mm of Hg, and SpO2 was maintaining at room air. BMI was 22.05 kg per meter square. On respiratory examination, she had a 16 per minute of respiratory rate, thoracoabdominal type, with bilateral air entry of normal vesicular breath sounds all over the areas heard. And on cardiovascular examination, first and second heart sounds were heard in all the auscultatory points without any added sounds or abnormalities. CNS examinations were within normal limits. On and per abdomen examination, it was soft without any organomegaly or any abnormality. On musculoskeletal examination, her left foot was first examined. As she told about the history which she started with. On inspection, at left foot, there was a lump of about 4 on inspection. The left foot single round lump or mass with a regular margin was seen at the lateral border adjacent to the left little toe, with a normal overlying skin without any scar mark, any sinuses, or any signs of inflammation. On palpation, it was about 4 into 2 cm in size, was non-tender, firm, rubbery consistency, fixed without any inflammatory signs, and lump was adjacent to 5th proximal metatarsophalangeal joint with mild restriction of the joint movement. At that time, we didn't have any exact image, so we just got it made. Then on examining the right supraclavicular region, on inspection, it was round supraclavicular swelling with a regular border and with a normal overlying skin and without any scar mark, giving sinus or signs of inflammation. It was almost similar to the one that we found in her left foot. On palpation, it was about 2 into 2 cm, which was non-tender, again firm to rubbery in consistency, which was not fixed without any inflammatory signs, and the lump was about 2 fingers above the right mid clavicle and provisionally looked like an enlarged node. There was no such swelling or lymphadenopathy at any other sites, as in cervical, axillary, trochlear, inguinal, or popliteal region. This is again a schematic image of the same what we examined in the OPD in the first visit. Then spinoskeletal examination. On inspection, the spine was normal without any obvious deformity. On palpation, tenderness was present, and it was about 7 out of 10, 10 of the pain score was there, and which was present from D5 to L5 region with a positive straight leg raise test, left more than the right side, and no evident sensory or motor deficit in bilateral upper and lower limbs, which we have seen in the CNS examination itself. So till now the patient came to us, and summarizing what we found till now, it was a 26-year-old female premenopausal with a painless rubbery swelling at her left foot lateral to little toe and enlarged lymph nodes at right supraclavicular region with constitutional symptoms and a low back pain for past 4 months with an FNAC suggestive of malignant cytology. With this examination and an FNAC, it was a very open diagnosis, and till now we had the working diagnosis of most common to have a lymphoproliferative disorder or a metastatic carcinoma or a metastatic sarcoma with spinal metastasis. Now coming to the investigations, she came to us with a FNAC report done from outside, which was suggestive of a blood mixed material aspirate, mildly pleomorphic cells with clustered fascions with scant cytoplasm, pleomorphic hypochromatic nuclei and coarse granular chromatin. Overall suggestive of a malignant small round cell tumor. Here I would like to emphasize one thing, that we very often get an FNAC done for most of the patient present with a lump or a mass in various settings, whether coming to a medicine OPD or a surgery OPD. But for in modern oncology and modern medicine, it's very difficult to make any diagnosis based upon an FNAC. It is a classical case. The patient came with a report of a cancer, that she has got a cancer with all the symptoms. She was worried, she wanted a treatment for which she came to us. But with an FNAC report with such an open diagnosis of malignant small round cell tumor which has got n number of differential diagnoses, it's very difficult to start the treatment. So anytime when a patient comes with a lump, it's always encouraged to get a proper tissue diagnosis done. Tissue diagnosis in the means of the true-cut biopsy or excision biopsy to comment, so that a pathologist can properly comment on the architecture of the tumor, the proper staining, and we can save the material further for some specialized tests which we can run in further. That adds a lot to the proper management of the disease. So I would request that whenever possible.
So in this particular case, I would like to add a few points towards Nishant for that. She is a young female presenting with sort of these symptoms. She is having classical palpable lymphadenopathy with similar characteristics that we expect from lymphoma. In such case, where we are having potentially curative diagnosis. So early diagnosis, starting treatment as soon as possible. Like if she comes out to be a lymphoproliferative disorder, then even in stage 4 we are expecting very good response rate and long-term survivals. So if we are getting tissue diagnosis by FNAC, so in every sense that's going to be very inadequate for OP. Like even if we are making diagnosis of lymphoma FNAC, still we are not going to do any further subtyping, and that's not going to aid into our further treatment decisions. So whatever treatment we are planning, that is going to be delayed. Like even FNAC takes few weeks, sometimes even weeks. Then even we are getting from outside, that can take up to 7 to 10 days. In our center, even if we ask earlier and we take 3 to 4 days, still 4 days are lost. So we are not able to start the treatment which is required as soon as possible, especially in lymphoproliferative disorder. So first message from the workup was that instead of offering FNAC, which when she is having 2 such discrete swellings, excision from the primary region or excision from supraclavicular node would have been much better approach. And my pathology man, she would agree that in diagnosis of lymphoma, the lymph node effacement, lymph node architecture, that is very crucial in making diagnosis of subtypes of lymphoma, and then further offering molecular subtyping. In today's oncology, everything is molecular. So whenever we are starting treatment, just making a diagnosis of lung cancer is not enough. Making diagnosis of breast cancer is not enough. Making diagnosis for the sake of lymphoma is also not enough. We need to know what is the subtype of that lymphoma, so that we can start the precision therapy accordingly. And that precision therapy is not in textbook anymore, that is in our clinics. So first learning point from this case, which I wanted to convey, and I want to convey very strongly to all my clinician colleagues, that excision or at least true-cut is not preferred in lymphoma, but at least excision or true-cut should be offered first. If that is not feasible, then FNAC plus cell block will be mandated. So just FNAC is not going to help to either pathologist or clinician.
Ma'am,
It was an outside.
outside only, ma'am. Ma'am, actually
There is some Western UP private clinic.
actually her husband was working.
That will be sometimes they write a telephone number, so we call and
Also, madam, nowadays, Tata Memorial Hospital, Mumbai, they have standardized flow cytometry from lymph nodes. In lymphomas, you can apply almost double the number of markers which you can do on IHC, and that will give the earliest diagnosis of lymphoma. It will supplement the biopsy, which will come later, but within 24 to 48 hours, we will have a panel of markers. So they have standardized it now in lymphomas.
Shall I go? So this was the investigation that she came with, and coming with a differential diagnosis of a small round cell tumor with such swellings, it was an open diagnosis. It's a number of differentials which include non-Hodgkin's lymphoma, ALL, metastatic carcinoma, Hodgkin's lymphoma, metastatic melanoma, synovial sarcoma, all the varieties of sarcoma. It can be liposarcoma, extraosseous seeding sarcoma, small cell variety of osteosarcoma, metastatic neuroendocrine tumor or carcinoma, and many more. So till now we were not having a proper diagnosis, not leading towards, so we further investigated the patient. We ran some of the routine investigations, and in CBC with differential counts, it was suggestive of hemoglobin of 6.2 grams per DL. As such, the total leukocyte count, differential count and platelets were normal, and hemoglobin indices were also normal. RFT was within normal limit, LFT was within normal limit, the albumin of 3.1 grams per DL, thyroid function test was normal. And we ran some of the tumor markers, and serum CA19.9, CEA, CA125 were found to be within normal limits. LDH was raised to 561. Iron profile was done to address the anemia. It was found to be normal. Vitamin B12, folic acid levels were found to be normal. A chest X-ray was done, which was normal, and an echo and ECG was done, which was normal and suggestive of 60% of ejection fraction. So now the next step in the diagnosis and management of this patient was to offer an imaging. So we offered this. So this patient has presented with a swelling in her foot, then a swelling in supraclavicular region, with all the constitutional symptoms, low back pain. So it was actually her. She was presenting with symptoms that actually persisting from the head to toe kind of. So we offered the patient for a CCT, contrast enhanced CT of thorax, abdomen, pelvis, along with a whole body bone scan, or a whole body PET CT scan. So here, as a class 1 indications, it's always indicated to get a CCT thorax abdomen pelvis for the staging workup. That helps to diagnosis as well. And for a FDG PET CT scans, this is recommended these days, especially for an adult patient, because many of the lymph nodal metastasis or distant or abnormal site lymph nodes involvement or subcentimetric involvement, they are better picked up by the PET CT scan. So it is recommended whenever feasible for adult patient to offer a whole body PET CT scan. Along with that, a whole body PET CT scan offers us the SUV, and this SUV change or the interval change on the treatment can further help us to make to direct us whether the treatment is going on properly or not. So we offered both the scans to the patient. The patient got a whole body PET CT scan done. A further adding advantage of PET CT scan is the patient need not to go for a bone scan further. It's a single scan that addresses all the pathologies, most of the pathologies. So a whole body PET CT scan done, which was done outside. It was suggestive of the first scan. The first is the first scan which was done was on 20th of August 2022. It was suggestive of a FDG avid. There was a strong FDG avid about 12.6 of SUV max at 12.6 of size of 5.5 into 6.5 centimeter right supraclavicular lymph node, and this was the one we examined also and shown in the schematic diagram. And then there was an FDG avid right paratracheal, the whole mediastinal lymph node basins were involved with a pretracheal, prevascular epindow and subcarinal with a strong SUV max of 9.9. Then the spleen was enlarged, and the spleen was enlarged with a strong uptake, with a diffuse uptake, and there was a diffuse uptake in the body of in the body and tail of the pancreas. In further images,
why is it on the other side? Images, this is
No, actually, he was pointing to nose. It is a extensive germline lymphadenopathy, and renal uptake and gut mucus uptake, brain uptake is physiological in PET-CT. FDG ability is physiologically high in CNS tumor, brain tumor, in renal parenchyma and pelvis and gut mucosa. Because physiologically, glucose uptake happens there, or glucose excretion happens in brain. The primary food for brain is glucose. So FDG uptake is physiologically high in this center. What was reported in PET-CT that she was in generalized lymphadenopathy with uptake in spleen and lymphoma like lymphoproliferative disorder like picture was presented. And so,
Left, right, or switching left?
no, that was left only.
No, this is left.
No, no, it's okay.
It's so,
That's
That
right.
is right and that is left.
And that one is
Left. Left is in.
He was pointing.
he was pointing towards opposite side.
I think he was right.
ma'am, that was the supraclavicular, right supraclavicle, and this was the spleen.
Normally we get the right orientation. Why is the orientation?
This is right.
No, this is right.
Yes. Supraclavicular is
This
right.
is pro and that is why.
Yeah, known position is this.
Point
Right.
Then in the
What point he was making that role of PET-CT. So, because that is important for us to understand, that is our not our in-house investigation, but that is crucial in making decision in terms of what is most appropriate site of taking a tissue diagnosis. Also, the pattern of SUV uptake will aid in making a diagnosis, even before the pathological report. That can aid in making diagnosis. That can help us differentiate infective pathology versus malignant pathology. Most importantly, we need to get at least 2 investigations if we are skipping bone scan. If we are skipping PET-CT, we need to add bone scan in addition to contrast enhanced CT scan. So there need to be 2 dates, 1 date for CT scan, 1 date for PET-CT. Especially for curable malignancy, that's again going to delay our initial treatment plan. And also during follow-up, in such patients, the single investigation will be required to see the response, whether the patient was having any response to systemic therapy or not. So all the across the guidelines, especially when we are suspecting malignancy of unknown primary, PET-CT is always a preferred investigation. And in this particular case,
There is which center?
we are not recommending at any particular center as such, but since there is cost difference between Delhi NCR and Uttarakhand, so usually we ask patients to get it done from Delhi NCR.
Ma'am, actually, the husband of this patient was working all in Yashoda. So in Yashoda, he got it done, ma'am. He got some subsidy there, so he got it done there. But so it was from
In Delhi NCR costs around 7,500, less than 7,000 rupees. Here in Jollygrant it's around 20,000 rupees. So the difference is quite much. So even if patient has to travel to that becomes cheaper if they are getting in Delhi NCR.
Then in the coronal section, we can see that there was a FDG evidence solid cystic lesion noted in bilateral adnexa, which was left adnexa more involved with SUV max of 8.6 as compared to right adnexa. And there was FDG avid omental, serosal, mesenteric uptake and deposits. In the musculoskeletal exam, in the musculoskeletal imaging, it was MIP, that is maximum intensity projection. We can see that the whole skeleton was involved. It was the FDG avid lesion was shown with the soft tissue component seen in the bilateral skull bones, mandible, multiple level of vertebra, bilateral humeri, bilateral scapulae. We say the bone, it is involved in the patient. So we got an imaging done. We examined the patient. We got imaging done with basic investigation. Till now, we were more focusing towards a disseminated lymphoproliferative disorder and less looking like other diagnosis, or we can label it as a carcinoma of unknown primary with metastasis. So next question was to get a tissue diagnosis done. So for which we consulted the surgical oncology team, and they reviewed the reports, reviewed the images and the patient symptoms, and examining the patient, they decided to get an excision biopsy from the left foot mass. So here also I would like to bring to the forum that whenever possible, it's always recommended in oncology or in other setups also, if a proper imaging done baseline, then we can actually get which tissues to be manipulated, which tissue to be taken. So whenever feasible, get the imaging done properly, and the most, for example, for this in PET-CT scan, most avid site is preferable site to get the biopsy or tissue sampling done. So here the excision biopsy from the left foot mass was done.
How much time since the patient presented? And
Ma'am, almost within 20-25 days, we got her admitted. Ma'am, because the patient was traveling for PET scan to outside, and her husband was working there, so he was always requesting to get more time. He was the only sole earner. That was the major reason, ma'am.
But from our side, there was no delay. The excision was done immediately.
Yes, ma'am. The same day we discussed in the OPD.
So you did the excision and then sent her for PET CT, so you would have got the report.
No,
by then.
ma'am. Ma'am, she came with a cytology report, and that OPD only we offered for the imaging.
Because you had two masses. You
Yes,
would have
ma'am.
done an excision and then got the, but then you would have lost the ability of that.
Ability, and maybe most appropriate region to get tissue, we would have lost that opportunity.
Then the biopsy was done and histopathology came out. It suggested the sheets of small stellate spindled or round cells with scant or deeply eosinophilic cytoplasm with eccentric small oval nuclei with light chromatin patterns and inconspicuous nuclei. Occasionally they showed presence of rhabdomyoblastic differentiation or the strap cells and few cells with elongated tails of cytoplasm suggestive of the tadpole cells. The report was made as malignant small round blue cell tumor. Again, a malignant round blue cell tumor is an open diagnosis. It has got n number of differentials. So for this, we have to undergo some important immunohistochemistry panels and molecular investigations. The same was as followed. And it was something which we were not expecting actually. The patient showed strong positivity for MyoD1 and myogenin with negativity of LCA, CK, CD20, CD3, SAL4, Langren, MPO, and a Ki67 of 50% with a grade 1 differentiation. Overall, it gave us a final histopathology of a non-pleomorphic rhabdomyosarcoma, which we were not suspecting for an age of 26 years old with such disseminated disease, with such symptoms to come as the diagnosis. The LCA negativity, CD20, CD3 negativity ruled out the hematological malignancies, and MPO negativity ruled out the hematological malignancy. SAL4 ruled out germ cell tumors. The Langren's also, the Langerhans associated diseases. So it came up, and CK negativity showed that it is not a carcinoma. So it's a sarcoma of non-pleomorphic variety, rhabdomyosarcoma. So once it's made a diagnosis of rhabdomyosarcoma, its further workup was different from other sarcomas or carcinomas. So as rhabdomyosarcoma is not a single entity, it's actually a variety of different entities inside the rhabdomyosarcoma umbrella. So for this, we needed to get a special investigation for FISH to see for FOXO1 rearrangement, which was found to be negative for this patient. I have discussed later also, the FOXO1 rearrangement actually determines whether the rhabdomyosarcoma variety is of embryonal type or alveolar type. Once it is positive, then it is suggestive of alveolar type variety, and it is prognostically poor as compared to embryonal. For this particular patient, we expected to have an alveolar type variety because of the aggressive nature of the disease, a duration of 4 months only, which was quite short for a sarcoma or rhabdomyosarcoma to present with, and overall adult patient presents with alveolar variety as compared to, not exactly adult, but the older children presents with alveolar variety as compared to the embryonal one. As a staging workup for the rhabdomyosarcoma, its bilateral bone marrow aspirate biopsy is recommended, and there is about 12 to 15% marrow infiltrations, and moreover this patient presented with such strong FDG avidity in the marrow. It was done, but it was found to have no malignant cells with a normal erythro and hematopoiesis, and with a normal hematopoiesis. So here comes the fact that the precision oncology for advanced sarcoma, that all the sarcomas are not same. We were not expecting such diagnosis for this age group patient, and getting such diagnosis actually brought so many things in the table, and we had to decide the further management for this patient. So RMS is not similar to other sarcomas. Its staging and workup, and staging of workup includes two important parts. First of all, a proper staging, which is not the classical AJCC staging, what we do for other soft tissue sarcomas or the solid tumors. It's different from them. And the second thing is that we have to risk stratify the disease. Since this is a pediatric, since this is mostly defined for the pediatric population, risk stratification is important, as the treatment is risk-based treatment is actually done for the rhabdomyosarcoma. So for TNM staging system for the rhabdomyosarcoma includes important points that are the site of the tumor. What is the site? It is described as favorable sites or unfavorable sites. Whenever it is the parameningeal sites, they are always unfavorable. And second thing is that the size of the tumor. As here we can see, that the size is described less than 5 centimeter or more than 5 centimeter. Then histological type, which further have been discussed, like whether it is alveolar variety or embryonal variety, that is favorable or unfavorable histology, the nodal involvement, and the metastasis. So this patient actually fall to stage 4 because of the patient with having the metastatic disease. It was having metastatic nodal involvement, so this patient belonged to the stage 4 group of rhabdomyosarcoma. Next was as I discussed, that we have to make a prognosis, we have to make a risk stratification, prognostication for this patient. So this patient, which includes the prognosis, which includes the stage of the disease, what we have staged as stage 4 in the previous slide. The stage of the disease, the clinical group, actually this clinical group comes from the surgical pathological outcome. So since this patient was not amenable for any surgery till right now, so this clinical grouping was not done for this patient. The site, coming to the site, it is coming to site, the favorable, unfavorable site, then size, the age of the patient, and then the FOXO fusion, whether it's embryonal or alveolar, whether it's metastatic or not, node involvement. So coming to this, all the factors came into the poor risk, that is poor risk or high risk variety with a stage 4 disease, with a metastatic stage 4 disease.
So then, alveolar sarcoma in adults is considered to have poor prognosis because it is associated with all the worst prognostic outcome pointers. So that's why adult RMS is considered a very poor prognosis factor. So these all inputs that we are discussing with, these all are classically for pediatric rhabdomyosarcoma. These are not for adult rhabdomyosarcoma. As such, there is no guideline for adult rhabdomyosarcoma. Even the international guidelines of NCCN, they recommend that is to be treated by a pediatric oncologist in consultation with pediatric oncologists who are well versed with dealing with rhabdomyosarcoma. So that means there is no clear-cut guideline how to stage, how to risk stratify, and how to manage this group of the patients. In literature also we are going to discuss all the experiences are from single center retrospective experiences or just case series of 3-4 patients, and everyone use their institute based guideline protocols for treatment and management. So whatever we are describing here, this is classical for pediatric rhabdomyosarcoma. Nothing is recommended for adult rhabdomyosarcoma. But having said that, this is classically described that adult sarcoma are having poor prognosis because all the worst prognosis factor for pediatric sarcoma are commonly found in adult rhabdomyosarcoma. So that is also seen in this particular case. She was having presentation of this extensive disease and all the metastatic disease presentation at the time of diagnosis. And all these are pointers of worse outcomes. Worse outcome means 5-year survival for majority of the patient, even in advanced setting, is less than 5%. So 95% of the patients, they are going to die within 5 years of diagnosis, including early diagnosis as well as diagnosis.
So now we have examined the patient, staged the disease. So it was a 26-year-old female with clinically soft tissue masses with low back pain, severe anemia, imaging suggestive of disseminated spinal metastasis, that is stage 4, with HPIHC suggestive of non-pleomorphic rhabdomyosarcoma with a FISH negative for FOXO1 gene rearrangement. So the final diagnosis came out to be high-risk metastatic non-pleomorphic embryonal type rhabdomyosarcoma stage 4 with severe anemia. So coming to the management. So we initially managed the patient, transfused 2 units of PRBC. Patient was given adequate analgesia for pain management and other supportive care. The patient was explained about the disease, its severity and the rarity of the presentation at her age. The family was counseled regarding advanced stage and poor prognosis, and appropriate contraception was advised to the patient and her husband. So the next question was to how to manage such case, because as such literature lacks a proper management guideline for an adult RMS of this type of this kind of presentation. So it was a proper MDT done, which for discussing the same points, that it's not localized disease, it's a high risk metastatic disease, an adult RMS, and what chemotherapy to give and how to manage the case. It was decided to give high risk pediatric inspired protocols that included vincristine, ifosfamides, etoposide, and for her bone metastasis, the bisphosphonates were planned to be given. And further therapy was based upon the response to the chemotherapy which we have planned, whether the patient will ever be amenable for any kind of localized therapy. The RMS management includes all modality. It includes surgery, it includes radiation, it includes chemotherapy. It's different from other sarcomas that one of the most radiosensitive, one of the most chemosensitive tumors, and whenever feasible, the local therapy has to be given in form of a surgery and radiation. But since this patient had such a disseminated disease, which included from head to toe almost, it was difficult to put any surgery. It was difficult to subject the patient for upfront local therapy in form of surgery or radiation. And chemo also was different from what we give for the classical pediatric high-risk protocols, which includes VDC, vincristine, actinomycin D, or doxorubicin and cyclophosphamide. So we decided to give VIE-based chemotherapy. The chemotherapy regimen was explained, associated side effects were informed. Dental examination was done for the eligibility of bisphosphonates. Cardiac respiratory examination was done for the fitness for chemotherapy. Then explained the patient and her husband was explained regarding the fertility associated issues, as the chemotherapy we were giving were associated with long-term side effect of infertility. The long-term risk of secondary malignancy were explained. Routine lab investigations were done before starting the chemotherapy, and a proper consent in written and informed form was taken before starting the chemotherapy. The chemotherapy regimen was of 21-day cycle. It included vincristine 1.5 mg per meter square from day 1, day 8, day 15. Injection ifosfamides, that is 1.8 grams per meter square from day 1 to day 5 with mesna. Then injection etoposide 100 mg per meter square from day 1 to day 5. The cycles were, as I told, that every 21 days cycles with a GCSF support, the colony stimulating factors support. Proper pre-medication and post-medications were given to reduce and other supportive medication to reduce any kind of adverse events. The patient was given zoledronic acids 4 mg monthly with vitamin D and calcium supplementation. Now our experience in first 4 cycles of chemotherapy. She was clinically examined at every visit in our OPD before the chemotherapy, and to look for her disease-associated symptoms as well as chemo-associated toxicities. Routine lab investigations were done before every cycle with adequate interventions if needed. For example, the patient was given PRBC transfusion in her initial 4 cycles. Following her second cycle, we found that there was a marked reduction in size of her supraclavicular lesion. She also told that she is feeling better with much reduced low back pain. And patient tolerated the first 4 cycles on her full dose without any dose adjustment, without any grade 3 or 4 toxicities. She received 4 unit PRBC, as I told, in her first 4 cycle and maintained a hemoglobin of 7.5 to 8.5 grams per dl. Now, the second scan or the interim scan or response scan was done on 2nd of December 2022 with comparison to previous scan. It was different. It was very satisfying. It showed that there was a resolution of previously seen right supraclavicular lymph node, decrease in size and metabolic activity of mediastinal lymph nodes, with most of them showing a complete resolution. Spleen size got normalized and FDG uptake significantly reduced in the spleen. There was a resolution of pancreatic uptake. There was a complete resolution of bilateral adnexal lesion and peritoneal deposit. And there was a metabolic resolution of all the skeletal lesions. Overall, it suggested a near complete remission, which we were not expecting at all. So these are the imaging with comparison. We can see here that the supraclavicular mass has gone. The whole bone involvement which was present in the previous scan has almost gone in the present scan. We see the pancreas, we see the paratracheal, the whole mediastinal pool of lymph nodes, the bones, that has completely changed in the new scan. These were the supraclavicular, the coronal section showed the supraclavicular in the previous one. It has completely gone in this scan. The humerus uptake has gone. Then it was at the pelvis, the adnexa which was showing the uptake, which has gone. The pelvic bone has improved. So it was looking like a complete response, which we were not expecting for this patient. We continued the treatment. We gave 4 more cycles of chemotherapy in form of consolidation, that is the same VIE chemotherapy which she received till the first week of 2023 April. She tolerated the planned cycles well without any residual toxicities. We did not modify the doses. The latest scan was done, which comparison of the interim or the last scan, we suggested the maintenance of CR at all the metastatic sites, and FDG avidity was seen at subcutaneous soft tissue in relation to the left tibio-talus joint on posterior aspect. That was the primary site, the first lesion that she presented with at her left foot. She is undergoing the consolidative radiation therapy at her primary site, and she is being planned for observation following the radiation therapy completion. She is receiving monthly zoledronic acid 4 mg with oral vitamin D and calcium supplementation, and she has been encouraged to practice adequate contraception. The plan of follow-up, it was different from what we do for the pediatric age group, since the disease was different and the presentation was quite different. So in view of poor prognosis and high-risk disease, a close follow-up was planned. 3 monthly OPD visit for clinical examination for disease and chemotherapy-associated long-term toxicities or side effects, routine lab investigations in the visits. 6 monthly imaging has been planned, and investigations and imaging as and when clinically indicated. So currently the patient is under treatment. She is undergoing RT radiation, and she'll be followed what we have planned in this manner.
So few points